just to get the formalities out of the way, I have no conflicts of interest to declare. So what is oncofertility? Okay, so this is a term coined by the Oncofertility Consortium in 2006 to define a subfield that bridges oncology and reproductive research to explore and expand options for the reproductive future of cancer survivors. So why is this important? Well, 10% of newly diagnosed cancer is in those aged 44 years old and younger. So basically those who are in reproductive years and even younger than that. And due to advancements in cancer therapy, survival has improved, but at a cost. These survivors often suffer from gonadotoxic treatment and are rendered infertile. Therefore, fertility preservation counseling and fertility preservation options is something that we should discuss with these patients because it enhances the quality of life of these survivors. Right, so based on this, the American Society of Clinical Oncology has recommended that as part of education and informed consent before cancer therapy, oncologists should address the possibility of infertility with patients treated during their reproductive years and be prepared to discuss possible fertility preservation options and refer patients to reproductive specialists. Despite this recommendation, the fertility preservation services are underutilized, and nearly half of oncologists never refer to a fertility specialist, owing to lack of knowledge of options available, perception that assisted reproduction are costly and of limited efficacy, and concerns regarding delay of cancer treatment. Although studies have shown that fertility preservation does not delay cancer treatment and does not affect the efficacy. So what are the requirements for a successful program? One, there should be rapid access of this program. It should be multidisciplinary, including oncologists, reproductive specialists, surgeons, pediatricians, counselors, and an experienced ART lab with proficiency in cryopreservation. So, oncofertility options are available for both the male and the female patients, but today I'm going to focus my talk on the female patient. And I took basically this guide from the Canadian Fertility and Andrology Society of what we should inform patients during informed consent. So I'm going to use as an outline. So I'm going to talk today about, sorry, the slides are actually doing this on their own. Risk of cancer treatment on future fertility. I'm going to talk about the fertility preservation options available and those that are investigational at the time being. I'm going to talk about the success rates of these fertility preservation options, and then I'm going to talk about alternative options and how to prevent cancer treatment ill effect on fertility. Right, so first of all, let's talk about risk of cancer treatment on future fertility. Okay, so the American Society of Clinical Oncology have divided the risk into a high, intermediate, low risk, and very low risk, depending on the probability of premature ovarian failure occurring after cancer treatment. And this risk depends on the age of the patient at the time of treatment, the fertility potential of the patient, the type of cancer diagnosed, and the type of treatment the patient is going to receive, and the dose of treatment that the patient is going to receive. So let's talk about chemotherapeutic agents. Alkylating agents, platinum complexes, and taxanes are the most gonadotoxic chemotherapies out there. Of all these agents that I mentioned, cyclophosphamide is probably the worst, as cyclophosphamide-containing protocols cause ovarian failure in approximately 80% of treated women within 1 year. So how does chemotherapy do this? So one, it increases recruitment of the primordial follicles available, so basically depleting the primordial follicle pool available, and it also causes apoptosis of the active follicles, therefore further depleting the pool, and it can also cause vascular damage to the ovaries. Right, so what about radiation therapy? Radiation therapy also causes also have gonadotoxic activity, and it depends on the site of radiotherapy and the dose of radiotherapy. So when we're talking about abdominal pelvic radiotherapy, as little as 2 gray of a dose can cause loss of more than 50% of primordial follicle pool. And just to know, just to have an idea, gynae malignancy require approximately 50 gray of radiation. So that's much higher than the 2 gray. If a patient receives cranial radiation, then 30 to 40 gray can cause central hypogonadism. So what are the fertility preservation options out there? So I've divided these into established options and investigational options. In the male, those that are established are sperm cryopreservation. And those that are investigational are testicular tissue cryopreservation and transplant. In the female, the established ones are embryo cryopreservation, oocyte cryopreservation, and conservative gynae surgery. What's investigational is ovarian tissue cryopreservation and transplants. So which ones should we choose? That all depends on the age of the patient, the diagnosis, the type of the treatment or the chemotherapeutic treatment or the cancer treatment the patient is going to receive, the fertility potential of the patient at the time of treatment, and availability of a male partner or banked sperm. Also, time available is essential to know, and the likelihood of ovarian metastases also determines which way we're going to choose. So, established options. First of all, embryo cryopreservation, and very like IVF, basically controlled ovarian stimulation is needed. Therefore, we need time to stimulate the ovaries, and basically a difficulty is those patients who carry a hormone-sensitive cancer, like estrogen receptor-positive breast cancer. So these patients, we have to add things like letrozole, which is an aromatase inhibitor, to keep estrogen levels down so that the estrogen levels that build up during controlled ovarian stimulation don't affect their cancers. There's also risks of OHSS, ovarian hyperstimulation syndrome, when we're stimulating these patients, and risks of ovarian pickup, so things like bleeding and infection. Therefore, those are things that we need to explain to the patient. And when we talk about embryo cryopreservation, sperm is needed. So basically, the patient needs to have either a partner or has basically banked sperm, if accessible. And the success depends on the number and the quality of the stored embryos. So what about oocyte cryopreservation? Again, it's very similar to embryo cryopreservation, but in this case, no sperm is needed. And the success, again, depends on the number and the quality of the stored oocytes. So just to put or talk about the success rates, and these are basically numbers that we've got from infertility patients using the SART data. And when an average of 1 to 2 embryos were transferred following embryo cryopreservation, the clinical pregnancy rate was between 52 to 53%. And when 1 or 2 embryos were transferred following oocyte cryopreservation, then thawing the oocytes and then fertilizing them, then the clinical pregnancy rate was between 36 to 61% according to the studies. The biggest studies showed actually a clinical pregnancy rate of 55.4%. So very similar outcomes. That's why oocyte cryopreservation was once investigational and now is an established method. All right, so what about fertility-sparing surgery? So ovarian transplantation is a way where we can actually move the ovary out of the radiation field so that when the patient receives radiation therapy, the ovaries are out of the field and receive less gonadotoxic effect. Other fertility-sparing surgeries are conization and trachelectomy for things like cervical cancer, and unilateral salpingo-oophorectomy and cystectomy for ovarian neoplasms. Okay, so investigational options. So I'm going to briefly talk about ovarian tissue cryopreservation and transplantation because our speaker will be talking about this in our coming sessions. So this is good for patients who have no time for controlled ovarian stimulation, who have hormone-sensitive cancers, and is the only option for pre-pubertal girls. It requires surgery, and it requires expertise in cryopreservation of ovarian tissue. And the patient should be of low risk for ovarian metastases and future ovarian cancer for this to be feasible. So basically, it's taking ovarian tissue, freezing it, and hopefully transplanting it once the patient recovers from her cancer. So there are two main techniques. There's ovarian cortical tissue cryopreservation and transplantation, where pieces of the ovarian cortex are taken and frozen, or whole ovary cryopreservation. I'm not going to say much about this because, like I said, there's going to be a talk on this. And for cortical tissue transplantation, the transplants can be either implanted orthotopically, so basically where the ovaries normal anatomy is, so in the pelvis or ovarian fossa, or heterotopically in places like the arm, the chest wall, and the abdominal wall. And using this technique, so far we have more than 60 live births from this. The last one actually being of a patient who froze her ovarian tissue at the age of 9, so pre-pubertally, and then went on to transfer that tissue in adulthood and conceived and gave birth to a child. So a little bit about whole ovary transplantation. So far, I do not know about any successful transplant of a whole cryopreserved ovary, although there is a successful transplant of a fresh whole ovary from a sibling twin to her sibling sister, which led to a live birth. Okay, so what about alternative options? So there's also in vitro maturation. So patients who cannot receive controlled ovarian stimulation because they carry a hormone-sensitive cancer or for other reasons, we can basically aspirate their immature oocytes and mature them in the lab. So that is an option as well, and it's investigational. And where available and permitted, and if patients cannot undergo the fertility preservation that we mentioned, egg, sperm, and embryo donation can be discussed, and also adoption. So let's talk about prevention of ovarian damage. As one of the ways that we can try to prevent what the gonadotoxic effects of cancer treatment does on the ovary. So the most established or the most investigated is our GnRH agonists, okay? And basically the hypothesis of using these are we use them at the time of cancer treatment so that we cause downregulation of the pituitary gonadal axis and cause the ovaries to become quiet and decrease the blood supply to the ovaries. The only thing is that the data has been conflicting on the use of GnRH agonists in this context. Large trials have showed that those patients who received treatment had less premature ovarian failure compared to those who are who are controls, but small trials didn't, and there were no studies comparing ovarian reserve and pregnancy rates in these patients. So basically, it could decrease premature ovarian failure in these patients, but we don't know what the pregnancy rates will be for these patients. Okay, so other methods of prevention of ovarian damage are basically targeting decreasing the follicular recruitment and activation caused by chemotherapy, decreasing apoptosis, and decreasing vascular damage. And there's also studies that use targeted transport mechanisms for the chemotherapeutic agents and encapsulations that are being undergone. So in summary, patients diagnosed with cancer have the right to be informed about the impact treatment will have on their fertility and what fertility preservation options are available to them. Early referral to a multidisciplinary team is essential. If an investigational fertility preservation option is used, then the patient should be informed about the investigational nature, and a research and ethic board approval is necessary to undergo this. And prevention of treatment-induced damage should be the focus of future research. Thank you very much, and these are my references.